This
I did.
conference will now be recorded.
Okay, so it looks like there's more people than I wrote down, but oh, Dennis, that's one that I didn't put down. So let me read who I've got down here, and then you'll tell me who I still need to add. So I've got Ken Anderson, Len Sierra, Alfat, Jake Hannon, Marguerite Florsham, Mark Finn, Elaine Genserek, Jay Mills, Paul Frieder, Dennis Correa. Did I miss anyone? Oh, and Peter. Peter just came.
Hey, Peter.
Okay.
And John Appler, too.
And John Appler, thank you.
Right. Someone else on the computer says waiting for name. I don't know who that is.
Well, we'll find out.
Yep.
We'll find it out. Oh, okay. So let me start going through people, and then we'll get cracking. I know certainly Mark, Rich Jackson just came in, and okay. And then we have one person on online who hasn't identified themselves yet.
I think that was Mark Finn. I finally got. Mark. Yeah, I finally got the GoToMeeting to go. So. Oh,
okay. Yes. Perfect. It's a very good. You got a great camera there, Mark. Too.
Thank you.
You look very clear. All right. Let me. All right. So, just a couple of things before we'll kick off with Mark Finn. We're getting some feedback. I wonder from who. So if you could just turn your volumes down a tad, and we'll see if we can get rid of that. Get rid of that feedback. It would be great. I just want to say briefly up front that there were well over 100 people at Eric's memorial on Sunday, and it was very sweet. You know, a lot of good speakers. There were a lot of laughs, and Eric was remembered very fondly. And as I mentioned in my email, there were a couple of people that spoke to his professional success in essentially developing the software that we use every day that allows us to use our credit cards online. And subsequently, he developed the software, the beginnings of the software to use credit cards with handheld devices too. And he sold that company out, and then essentially lived in this enormous, beautiful house that he rents out some sort of cottages and some rooms. It's an enormous house in a very fancy area on the east, in the East Bay of San Francisco, a place called Orinda. And I mean, one of the people that spoke, there were a number of good poems or readings. So one of them was, you want a physicist to speak at your memorial, which is a short poem written by a guy called Aaron Freeman, and one of his former partners read that, and then he wrote something from Tolkien was also read, which wouldn't surprise us if, for those of you who knew Eric, wouldn't surprise you much. But by and large, it was good, and we got a bunch of kudos, which was great, and people came up to us and afterwards to me and thanked me, and because nobody really spoke to what Eric had gone through the past 5 or 6 years, which is what I did. Interestingly enough, one guy came up to me, and John Steinberg, I think his name was, and he's an old friend of Eric's from Cal. And he said to me that he had surgery when he was in his early 40s at UCSF in 1996. And he looks terrific, this guy. He certainly looks a heck of a lot younger than his age. And his surgeon back in 1996 was Peter Carroll, who he liked very, very much. So, you know, it's just interesting. And he also was a close friend of Eric's, and he was aware of what Eric was going through because he was the guy that was often taking Eric to chemo. Anyway, that's just a little taste of what happened. I also had the chance to meet with a guy who I don't know if we'll ever get him on one of these calls, but he's a buddy of my friend Dave's, who I was staying with. He's a jazz drummer and a very good one. And he was diagnosed 2 years ago, but he didn't like his doc. He was diagnosed at Kaiser. He didn't like his doc. And the doc called him up and said, "You must be here tomorrow because you've got to start treatment." And he never did it. And, he was symptomatic earlier this year with some urinary blockages. And he has a PSA of 193 and metastasis. So, you know, it's just a further indication that you can't let this disease go. You've got to do something about it. You know, one would think that hopefully his disease isn't too bad, even though he has metastasis, because he's gone 2 years and he still looks fine and he's doing okay right now. And I've sort of we've directed him to some good doctors at Kaiser, so we'll see what happens. But we may get him on the call. I'm not holding my breath, though.
Did I read correctly that Peter and Eric were cousins? Did I read your eulogy correctly? That Peter...
No. It was not a cousin. It was a cousin of Eric's that called me.
Okay.
There was a cousin of Eric's. Marguerite may remember this. Because this goes back to around 2013 on Inspire. And I was debating with a guy called, I forget what his name's Peter Hahn. I forget what his screen name was, or Len may even remember it. And we were debating about PSA testing, as fairly frequently happened then. And he was opposed to PSA testing, but we had a very respectful debate. And in fact, he even sent me something to edit that he wanted to publish to make sure it was correct. And then he called me up one day and he said, my cousin had surgery and doesn't look like they got it. He lives in your area, because that's where I was living at the time. Can he call you? And I said, of course he can. And then he never did. And what I found out was that his sister, who was a therapist, was in on this, and she kept calling Eric and said, Eric, you've got to call these people. They're going to give you good support. And that's how he came to us. Okay, so let's start with Mark, Finn, if that's okay with you, Mark. What we usually do is if we have people on the call who are new to the call and never been on before, we give them the opportunity to talk a little bit about their situation first. And if you're comfortable doing that, we'd ask you to just give us a quick background on yourself, your age, your disease demographics, where you're being treated, and what issues you're facing right now. And, we'll spend about 20 minutes to 30 minutes with you. Take as much time as you need, and then we'll just kick around the issues. And Mark came to us this week through Terry Lakowski at us too.
Rick, I think that
Okay, well,
feedback is coming from you.
You think the feedback is coming from me?
I believe so. I don't see anybody else in the talking box except you, but I keep hearing a lot of echoes.
Me too.
Yeah, I don't think it's coming from me. It'll get picked up by anybody that's online, and if it's coming from me, you'd see it twice, I think. But anyway, go ahead.
Okay.
But I'll turn my volume down.
It may have been me. I just switched to my earbuds instead of the computer speaker, so hopefully it's better.
Careful where you point that finger out, Annam. You're regret it, man. Okay, go ahead, Mark.
well, first of all, it's nice to meet you all, although virtually. And again, I was talking to the folks at us too, and they suggested you might be another resource for me. Just as a really quick background, I'm 66. I was diagnosed in October of 18 or August of 18, so it's been about 3 years ago. And when I was first diagnosed, I had a PSA of about 6, and I was diagnosed with stage 4 metastatic disease. And so what I decided to do is I went ahead and proceeded and had a prostatectomy. So and then right after the prostatectomy, I had Taxotere chemo, and then also went on androgen deprivation therapy. So that was sort of where I was at, and I had a pretty low PSA for about a year or so. At one point, then I went off the ADT with the idea of doing intermittent therapy instead of constant. And that worked for about 6 months or so. And then my PSA started to rise again. So I went back on ADT, and I've been on that since. And then about 6 months ago, my PSA has started to creep up again. And so at that point, I've went through and did a Provenge treatment and completed that late last year. And so right now, my PSA is kind of stable. It's around 4. It's creeped up anywhere from like 0.03. It was doubling initially, but now it's around 4, and it's sort of stabilized there. I'm not quite sure yet of what the impact might be of Provenge, or whether this is just a noise in the analytical system. So the next thing for me will be looking at proceeding and getting Xtandi, as I'm becoming castrate resistant, or I am already. And so one of the things and we can talk about it later, but if any of you had any resources around the fact of if there's any documents that sort of give you some guidance as far as when is the best timing to take Xtandi and to start with your next level of treatment. Do you immediately when you start becoming castrate resistant, do you just go ahead and get on it because let's get out on it early, which I think some physicians will tend to lean towards. Another choice would be to wait until such time as my PSA starts to really rise significantly again, and then start Xtandi. So my oncologist has sort of said, well, it's up to you. And so I'm trying to just get a better feel for that. I realize that if I went on Xtandi, there are some additional side effects, but in general, except for fatigue and a body shape I don't particularly like, the ADT, I've been able to pretty well manage it, and it hasn't caused severe problems or severe impacts on my style of life and so on. So that's kind of where I'm at. I don't know. Did they leave out something where you folks have a question?
I think you did a pretty good job. I'm not sure I got the just run through that timing sequence again. You were diagnosed with bone mets in 2015.
Yeah, August 12. I'm not sure exactly. Probably the metastases were actually finally identified It was late 2015, but I went ahead and
Okay.
decided to have surgery. I realized that
Right.
some people will say, well, why do you have surgery? You should just gone right to radiation.
Right.
Because
Right.
it already had escaped the prostate. So back and forth with my surgeon about that. And we decided that this would be an aggressive approach to being able to go after it. Yes, you have to live with the potential side effects, but overall it seemed like the right thing to do. And I'm still, it was a flip of the coin, but I'm still pretty comfortable with that decision.
Yeah. I mean, it's a shame that Carl Foreman isn't on the call today. It's a fellow that was found himself in your situation and decided to go into a clinical trial and had surgery about 6 weeks ago, metastatic, and it's a trial to see what difference debulking makes. So, but you'll be on when he's on, so you guys will have time to speak. And so you went on, and then you pretty much immediately after you healed up from the RP, you did chemo and ADT.
Yeah, we started. In fact, I think we started chemo right away. I'd have to check my records for sure, but I had the surgery in October, and January 1, I went through Taxotere, which was, I believe, 3 weeks apart for six doses of that.
Okay, and then you did which drug were you on? Lupron?
No, initially I started on Trelstar, which actually I liked. It has a few less severe side effects than Lupron.
Okay.
But I'm on Lupron now, and it's fine.
Okay. And then you stayed on, this is sort of where I got a little lost. You stayed on for how long?
I probably initially stayed on Lupron for about 9 months, and then I took a holiday from it for about 6 months. And then when my PSA started to go back up again, I went back on Lupron. I've been on it since, and I'll probably die with a needle in my butt with it or wherever. So.
Well, you'll talk to there's a couple of guys on here who have pretty advanced disease who are still taking holidays. So don't despair.
Oh, it's not despair. I think it's
Okay.
very, again, the side effects are annoying. They're very manageable in my case. I know some people, the Lupron, and particularly then when they do the Lupron plus Xtandi, the fatigue can be debilitating, but so far it has not been that way for me.
That's great. So you went back on around in sometime in 2017?
Yeah, I went back on. It was yes, probably in late 2017, early 2018.
Okay. All right. And yeah, we've also had a couple of guys again that have done Provenge recently, which is good. So we can definitely address the Xtandi question. What else is on your mind other than Xtandi? Anything else that you would like to bounce off this illustrious brains trust that we have here on our?
No, I think that to me is, my decision right now is, as I've said, my oncologist is leaning towards, well, we'll let your PSA as it starts to creep up. Eventually, we'll go to Xtandi, but that's kind of up to you.
Okay.
Partly quality of life issues there. Plus, I think sometimes oncologists like the idea of they only got so many bullets in the gun, so they don't want to shoot them all at once. So
Right.
they want to keep some in reserve.
Definitely.
Yeah, and I'm also thinking of potentially getting into a clinical trial at University of Chicago, which would involve taking Xtandi in conjunction with another developmental drug called mispriderone, and I wouldn't necessarily be receiving the mispriderone. Once if I entered it, they flip a coin, then you either get the Xtandi alone or the mispriderone and Xtandi. But that's something I might consider as well.
Okay, so we can talk about that too. But what is the drug again? Say it slowly.
Mispriderone. I will spell it for you. I have it here somewhere. I'll get back to that.
Okay. Okay. Yeah, please do, because we like to look at.
Any questions while I'm looking up mispriderone?
Who's running the trial? Is it a Walter Stadler or?
It's one of his colleagues at UFC, but
Yeah.
I would do it. Dr. Stadler, Walter's my oncologist at UFC.
Ah, well, that's what I was going to ask you. So, did you have your surgery at UFC as well?
No, I actually had my surgery locally with a local
Okay.
with a local urologist.
Okay. Well, we're fans of Dr. Stadler. We've had
Just for your information, the name of the drug is mispriderone, so it's spelled MIFEPRISTONE. And I think when I first looked it up, they said it was actually a drug which appears in some morning after pills for women who want to have have drug-induced abortions.
So let me just read that back to you because I think I'm not sure I got it right. M as in Mary, I, F as in Freddie,
Yep.
E, P as in Peter, R, I, S as in sugar, T, O, and E.
That's it.
Okay.
It's an experimental drug, and they're looking for. They've done the clinical trials where they've looked at dosage and so on. Now they're moving on to actually looking at what they do as far as in conjunction with Xtandi.
Okay. So I think Dr. Stadler is a terrific doc. And the couple of people that we know who have seen him also like his bedside manner. They find him easy to talk to. What's your response been to him?
I got a lot of time for Stadler. I think he's really good, and it took me a while to kind of develop enough of a relationship with him that he's comfortable with it. He's not necessarily the kind of bedside manner where he comes in and just spends time chatting and so on. I think he tends to be pretty conservative, but the nicest thing is that he's very frank. As he said he never would have had me have surgery. He would have gone right to radiation, and I understand that. He understands the debulking decision, but he would not have done that. Additionally, he's very big on the fact that that I need to get on Xtandi right away. The only delay I've had in that is that because two things. Number one, my PSA actually was not jumping up quick enough to actually qualify for the clinical study. And secondly, I decided to do the Provenge first, and he wanted me to, he didn't want me to have Xtandi and Provenge at the same time because they don't want to start you in a study on two things. They only want to start you on one. But beside that, I think Stadler's really good, and I always recommend to all my friends and prostate brothers that you should have at least one of your physicians you're working with, at least one should be associated with a university because you get much more of a up-to-date sort of view of things. Absolutely.
So let's Jake, you want to talk a little bit about going on Xtandi? Is that a good person to start off with?
Yeah. Hi, Mark.
Hi, Jake.
Sorry to hear you're joining the club here with us, but welcome.
Yeah, it's like Marx used to say, you don't want to be a member of any club that would have you as a member, but so be it.
Well, I've been on. I was on Lupron since June of 2012. It worked for several years, and then I went to apalutamide. I worked for almost a year, and then my PSA started going back up. I'm a Gleason 8, and then I've been on Xtandi, and will have been on Xtandi for 2 years in February.
Okay.
Finally, it has worked for the longest time, but now it is starting. My PSA is starting to rise again, so I need to find out, what my next step is. But I got a good 2 years out of it. I hope to get a few more months before it starts rising too much.
Yeah.
The side effects you mentioned already, The fatigue is probably the worst. Lupron makes you tired by itself. The Xtandi kind of doubles that.
Yep.
It causes me to have some balance issues. I had to be very careful climbing up and down steps.
Right.
I just make sure I hang on to a railing.
Mhm.
And I get a little bit of weakness in my legs, but other than that, the side effects are very minimal. In fact, for the longest time, I had lower back pain, and once I started on, and almost from the very beginning, and once I started on the Xtandi, the back pain actually got better.
Huh.
So,
what was your Gleason, your post-surgical Gleason, Mark?
9, 4 plus 5.
Okay.
I mean, I always like to be the best in the class,
I just want to, we don't do this, but I know Mr. Jackson is leaving. Mr. Jackson, how much longer do you have with us? No, we
He might
see
be
your
on
mic.
About 9 minutes.
About 9 minutes. We've got a few more people I want to talk to for Mark, but I meant to go to Rich right at the beginning before we started, and I forgot.
That's fine.
And the reason is because we're starting a new call on Thursday, which Rich is going to moderate. And Mr. Hannum may be in the background to help him a little bit with the admin stuff. And I just would like Rich to do a quick promo because he has to leave to attend a local support group. So a local US2 support group. So Rich, you just want to talk for a couple of minutes and then we'll go back to Mark Finn.
Certainly. The call it's an emotional support call or emotional support group. It's the things that we don't discuss among ourselves or occasionally don't even discuss with ourselves. The anxiety, the depression, the fear, did I make the right decision? Where NCAN will be starting that call Thursday at 8 p.m. Eastern time. It will be the exact same connection routine that everybody has become used to here. Same phone numbers, same ID numbers if you call in on the phone, same web address. We're not going to get into the technical side. I think Rick's got that pretty well covered along with Peter. So we're going to be hitting the touchy-feely stuff that we don't talk about. You wake up at 2 in the morning and you sit on the side of the bed and you try to figure things out, or you start thinking about something and you start crying. And I've done all of that. We may not find an answer. What we'll try to do is help you feel better at the end of the call than when you joined us. If you find an answer, then we appreciate it. It's going to be for new people, for returning people that have biochemical recurrence, or anybody in between. So we could use some experience to, well, I've been there, I've done that, and here's how I handle it. We'd be happy to have anybody and everybody here join us. It is a men's only call. That's the limitation, but it will deal with any cancer, breast cancer, men's breast cancer, prostate cancer. It's not going to be specific. We're all dealing with side effects. We've all got emotional baggage that we didn't have before the doctor told us, and we would be more than happy to have you join us, and we'll try to unpack it and at least cut down on the amount of baggage you may be lugging around with you. Thursday night, 8 p.m. Eastern.
And the added bonus of listening more to that mellifluous baritone. So tell anybody as Rich said, it is for all cancers. It's not just prostate cancer. So, you know, if you know men, melanoma, lung cancer, colorectal, whatever it is, and they want to unload a little bit, this is a good place and a safe and secure place to be doing that. And it's all peer led. So there's no professionals in there. And thank you very much for moderating this group, Mr. Jackson.
My pleasure.
Okay, we'll see you on Thursday night.
All right. Take care, guys.
Before we send Rich on his way, Rick, we have to ask, I don't see those long locks behind your neck. Did you cut them off? Or, oh, there it is. Okay.
There they are.
I get home from work late.
Okay. I was just going to say, we do have a posting on Inspire that I put up there on Jan 9th. If anybody would like to go back to that posting and just write a little follow-up, we'd appreciate it because it brings us back up to the top of the list. So please just, you know, even if it's, you know, we've done these virtual groups, they're really easy to join or something like that. We'd appreciate it a lot. We just want to get it into focus between now, today, tomorrow, and Thursday. Just get it on the list. So I'm sorry to interrupt our session with you, Mark, but I just didn't want to lose Rich before he went off. Who else would like to talk to Mark a little bit? Who's on the call right now?
Rick,
Hi. Go ahead.
I'd just like to make sure that Mark is aware. I just took a quick look at this mifepristone. Here's what I read in a phase 2 clinical trial. It says mifepristone had limited activity in patients with CRPC and stimulated a marked increase in adrenal androgens, testosterone, and DHT. That to me is a recipe for disaster in someone with advanced prostate cancer. I don't understand the logic behind using this drug in prostate cancer. Did they explain this, the rationale, Mark?
Yeah, they did, and it's I'm not aware of because I thought the clinical trial #1 was mostly, the first phase of it was mostly around dosages, but they probably also looked at some other stuff as well. Do you have can you send that to Rick, and Rick could send it on to me as far as the study, the link from where you're getting that?
Sure, I could put it in the chat box too.
We'll put it in the chat box.
Yeah.
So if you look in the GoToMeeting box, there's a window underneath all the participants that says chat. Okay. So there you go. It's in there. So if you click on that,
you can get to it. Okay.
Yeah.
I wonder, you know, based on what Len just told us about stimulating the testosterone and DHT, I'm wondering if it may not be similar in concept to the BAT therapy, bipolar.
Yeah, I was wondering the same thing, whether the idea is to stimulate the androgen receptors that are not responding to the enzalutamide. But I don't know. That was what I was thinking.
Well, I'll take a look at that, and I have a copy of the study proposal. I'll go back and read it again and see if there's something in there that I missed.
Great, and let us know.
Thank you for that, Len.
Yeah. Was it Elaine? Was it you that wanted to speak, Elaine?
Yes, Rick. Thank you. Just quickly, thank you again for putting me on to Bill Burhan's. It was a very useful call, and I just as a reminder to some of the other fellows, my husband was just diagnosed with 2 small lesions in his liver. The scans show no evidence of any mets anywhere else other than these 2 small lesions. We got the word today, Rick, that...
Hold on a minute, Elaine. We'll come back to you for sure.
Okay, okay.
I just want to focus in on what issues I thought you had a question maybe for Mark.
Oh,
So
no,
we'll come
no,
back
sorry.
to-
No,
Oh,
sorry. Okay.
I thought I heard someone else's voice who wanted to talk to Mark.
Yeah, hi, that was me, Al Fott.
Oh, I'm sorry, Al. Okay, please go ahead.
So Mark, we've been on a remarkably similar path. I have a Gleason 9 5+4, so I'm ahead of you in that respect. I don't know if you're oncologist. I'll save my discussion about it, later when I talk about my situation. But I opted, instead of adding Erleada onto the Lupron that I was taking, I opted to take the Erleada as a monotherapy to see what it would do, and it had really very positive results. And I wondered if you could consider that possibility, and then while you're waiting to get into the trial, you'd have an idea to see how that did, and it wouldn't preclude you from entering the trial, but you might get lucky and have a positive response like I did to it.
Yeah. Now that's a good thought.
I
mean, I had a spectacular response to it.
Yeah, and there is, if you look at our history on YouTube, the recorded calls, Mark, we did a session with Al. I can't remember how long ago was the session that we did with you, Al? Do you remember?
It was about 2 months ago, because I've got a couple more data points since then.
Okay.
Maybe it was November. So.
Okay, so we did a session with Al. It'll be on there where he talks extensively about monotherapy with apalutamide, Erleada. You'll hear Al sees Dr. O, as does Len at Mount Sinai. So and I see Thibaut just joined us, which is great. Is there anyone else that would like to say anything to Mark before we move on? Because I want to be sure we leave enough time, because I think there's a few people that need some time. Oh, and I see Jack Flanagan just joined us as well.
You also mentioned Carl Foreman, that you wanted him to say, so you thought he'd had something to say to Mark. He's on here.
No, I just arrived, so I wasn't sure about what the topic was relating to Mark.
So Mark, just again, if you wanted to send me your PSA test results, I'd be glad to, graph them and send you back a picture of what they look like, so you would have that as a point of reference. That's one of the things I do, and you're certainly welcome to take me up on that.
Where would I say those? You say send you my PSA results?
Yeah.
Going back how far?
As far back as it's no problem to do a couple years worth of it. But mostly what you're concerned about is the period after the chemotherapy, where you were on and off. What you want to look at is your rate of change over time to see how that's changed, because that's going to be your best measure of how you're responding to treatment. Changes in your doubling time over time. That's the best metric that I think an individual patient can use to determine, how he's responding to treatment. So I'll calculate that for you, and then you'll have that as a frame of reference.
Well, thank you for the offer. I'll be glad to do that. Where would I send that to? Is there a place to paste that, or do I get do I go somewhere to get an email address to send that to you?
I'll send you Al's email address afterwards, after the call.
Yeah, thank you.
Len, do you have Al's email address? You're muted, Len.
I'm sorry, who were you talking to?
Len.
I do.
Oh, Len.
I do have it, Rick, and I can forward it to you. I mean, I don't have it handy at the moment, but.
Oh no, what I was going to say was, could you put it in the, could you send a chat message to Mark Finn with it?
Well, all right, I'll look for it and I'll put it in there.
Thanks. Okay, so just send it directly, personal message to Mark Finn. If that'd be great. Thanks.
Okay.
Thanks a million. Okay, well, look,
Thank you, Len.
I just want to mention to Carl, we can't, unfortunately, we don't have the time to recap, but Mark Finn made the decision to when he was diagnosed with metastasis to do a radical prostatectomy 3 years ago. He followed it up with chemo and androgen deprivation therapy. He's been on some intermittent androgen deprivation therapy. He's just turning castrate resistant, has done Provenge, and he's figuring out what to do next. So if you and Mark would like to talk to each other, you can send each other notes through the chat, personal notes, and exchange your telephone numbers or your email addresses. I had mentioned to Mark early in the call that you had just done a radical prostatectomy in a similar situation.
Okay, that's correct. I'd be glad to speak to you, Mark.
Okay, great, thank you. Real quickly, question
Yes.
I had back to Len is that it was from my looking at information is the, Erleada, the apalutamide, is currently only approved for non-metastatic disease. Is that correct?
That's my understanding,
Yes.
yeah.
Yeah, that's why apalutamide currently, I like the idea of the fact it doesn't cross the brain,
Barrier.
it doesn't cross the brain barrier, but right now it's just not approved for metastatic disease.
Yeah, but these docs have ways and means of making things happen. As if you listen to the call, when we get to Len and we get to Al, their doc has found a way to get it to them. So, and they may not actually clearly be eligible because both of them are to some degree metastatic, and Al is definitely taking monotherapy apalutamide right now. But we'll come to that when we check in with Al. So I want to welcome Thibaut. Hello, how are you? And we will. How much time do you have for us today? You're muted. Yeah, now you're good. Oh, we lost you. We lost you. I don't know. You're showing that you're not muted, but we can't hear you. No. Wait a minute. Something's happening here. Can we hear you now? No. All right. Now, we'll check back with you in a minute. We'll come back to you in a minute, but we can't hear you. Sorry. Okay. Let me run down the list and see who needs some time, and then we'll figure out from there. So, Ken, would you like any time today? Is Ken still with us, or did he leave? Yes, he's still there. Well, he may have stepped away, so we'll come back to Ken. Len, would you like any time today?
Well, you know already, Rick, what my update is, so only if we have time near the end, but not important.
No, you need to give your update. We gypped you last time, so we're not gypping you today, okay?
Okay.
Alfat, we know that you would like some time. Jake, do you need any time?
Sorry, I was in the bathroom. No.
Okay. Marguerite, would you like some time today?
I have a quick question.
Okay, we'll come back to you. Elaine, I know you need some time. Jay Mills, did you want to give us an update?
Sure, that'd be fine. Pretty
Okay.
brief.
Okay, Paul Frieda, anything for you?
Yeah, I want to talk about costs of the 3 secondary drugs. I may be going on one of them at any time now, and also a little bit about statins.
Okay, well, we may not have time for both, but we will try. Peter, anything for you? Peter, is Peter still with us? No.
No, he left a while ago. Rick.
Okay. No, Peter. Dennis, anything for you?
Not for me, Rick. I'm good. Thank you.
Okay, John Appler, anything for you?
I'm good also, Rick. Thank you also.
Thank you. Rich is gone. Thibaut, we will definitely check in with when we have a connection. Carl Foreman, anything for you?
Yes.
Okay. Larry, anything for you?
No, not tonight. Thank you, Rick.
Okay, and now we also have Jack Flanagan, who's a new person. So I'm going to give Jack, I just realized that. I'm going to give Jack, if you'd like to tell us your situation, we only have about 15 minutes for you, but we can certainly make 15 minutes. Does that work for you?
Can you hear me okay?
We can hear you fine, and Jack also was referred to us this week by us too. So tell us a little bit about your situation, your disease, and we will and then crystallize what you'd like us to help you with, and we'd be happy to do it.
First of all, I'm overwhelmed with all the knowledge and medical jargon here, and I feel like a babe in the woods. I'm 73 years old, and I was diagnosed with prostate cancer and had radical prostatectomy back August 28th. And my dilemma now is whether I should go on with. My dilemma now is whether I should with surgery. I'm sorry, with radiation or not.
Okay, sorry, we're getting feedback off of, I think it's coming off of this caller number 8, which we'll check in with them. Yeah, it is.
Is that any better now?
That's fine now. Yeah, we're doing good. So you had surgery back in August
28th. Right.
August 28th, and tell us a little bit about your disease. What was your Gleason? What was your PSA before you had the surgery?
The PSA was about 7. My T-score was 3, and my Gleason score was 9. So they said it was very aggressive, and that I needed to do something about it. So I was hoping that the surgery would take care of it, but now they're saying that there's a possibility, a 50% possibility that will return. So I'm weighing whether I should have radiation or not. Now, my brother went through a similar process 15 years ago, and he had a lot of bad side effects from the radiation treatment. So he suggested that I wait with the radiation and just follow the PSA. If that increases, then to have it. The medical field, everyone seems there to say, do the radiation now.
Okay. What was your Gleason, a 4+5 or a 5+4?
4+5.
4+5. And where are you being treated, Jack?
Mass General in Boston.
Okay, and who's your who's advising you at this point in time? Who's your main man in terms of your medical team quarterback?
I have two people that advise me now. Let me just skip here. It's Jason Estefano, I'm probably mispronouncing it, and Matthew Smith.
Okay, Matthew Smith, I definitely know. He's the, I don't know him, I know of him.
Right.
And he's one of the GU Radoncs, medical oncologists who's there, who's very good. We tend to know the docs at Dana-Farber a little bit better and have a relationship with them. Do you like Matthew Smith?
I do. What I don't like about Boston is that it's a wicked commute for me. It can be 2 hours in good weather.
Where are you?
I'm more to the Lowell area, about 29 miles west of Boston. But because of the traffic and so forth, it's a heavy commute.
Yeah.
And this would be 7 to 7.5 weeks of radiation, 5 days a week.
Right. Well, I mean, let's talk about the logistics after we talk about the decision. The decision the advice you're getting is backed up by lots of good studies. And let me also say, don't be intimidated by, I mean, some of us have been dealing with this for years and years and years, and we're immersed in it. And if you don't understand anything, you stop us, you tell us to explain it. If we're over your head, we'll help you figure it out. But what we can tell you, and we can send you the studies, is that the studies show that with people that have high Gleasons like yours, that the sooner you follow up with both radiation and androgen deprivation therapy, not either or, but both, the better are the outcomes. If you don't want to hang around when you've got 4+5 disease, did they find anything outside the capsule when they did the pathology?
Say that again.
Did they find any disease outside of the prostate capsule when they did the pathology? Was there anything in the bed or anything in the seminal vesicles?
No, I'm trying to think of the terminology. The vessels that they removed, that came back negative. My PSA is down where they want it to be. There's no cancer showing up in that. So that's the only good news I've had along this ride.
Okay, no, I mean that is good. So the other thing that I want to do, and then I'll throw it out to some of the guys, is just to tell you that the advancements in radiation therapy over the last 15 years have been immense, absolutely immense.
Good.
So what your brother went through 15 years ago is not comparable with the type of treatment that you'd be getting today.
Okay, great.
And the likelihood is that whilst you're going to suffer some side effects, they're not going to be to the same degree as your brother may have suffered 15 years ago. And I think it's really important to sort of bear that in mind. And
he is still dealing with the side effects. He went through a hyperbolic oxygen chamber to try to reduce them. That had reduced them somewhat, but he's still dealing with them. Right.
And did he, I hope he didn't have any eye problems as a result of that, did he or not?
No, that actually improved his eyesight short term.
Okay, because we did have somebody who had horrible eye problems when they went through the hyperbolic chamber.
Now, besides the radiation, what was the other treatment you were talking about?
Androgen deprivation therapy.
What is it?
Hormone. Androgen, ANDROGEN, deprivation therapy, ADT. That's, you've heard people talk maybe about Lupron.
Yes.
Hormone therapy.
Yes. They said that they didn't recommend that at this time. They're recommending just the radiation.
Well, you know, the studies say that the two should be going together. And I would, we're not docs, but if it were me, I would not. And we'll visit around a couple of guys quickly and get the response. But if they're telling you to do the radiation without the androgen deprivation therapy, I would strongly encourage you to get a second opinion.
Okay.
Strong, and we can direct you to a couple of people that would be good for second opinions. But let's, in the interest of time, we'll take another 5 minutes or so. Who has wrestled with recurrent disease and had to make the decision on when to dive into radiation? Is there anyone on this call that applies to? No? Where's Peter when we need him? No, we lost Peter's not around. Okay. Who would like, we don't have anybody with direct experience today. We do, but he was on and he left. And I was hoping he would have, but I'll connect you to him. People are coming in all the time. Peter, are you back on yet? Okay.
I'm not sure if it's Rick. It's Paul Frieda. I remember after my prostatectomy, I was advised to try radiation therapy also, and I just made a decision not to do that.
Right.
Right. And so in retrospect, that meant that I probably gave up a chance to get a cure, but at the same time, my reasoning was that the potential to damage the bladder and the colon and other things just seemed be something I didn't want to have to live with, considering that there was just so little cancer in there after my prostatectomy. So I don't know if in the long run whether I'll regret that decision, but I decided not to do the radiation.
How long has it been since your surgery?
I had the surgery in April 2014, and so we're talking 5 years now. I've been on Lupron for 3 years, and I just stopped to take a vacation on that, and we're going to see how long it takes before it comes back. For example, if it comes back very quickly, like let's say next month, then maybe I'll start to regret that decision. But if I get the 2 years that my oncologist seems to think that I might get, then maybe it was a better decision, because you have to consider quality of life. If the radiation is, other normally function, you don't want every time you have to, go to the bathroom to have, pain or problems. And so I decided against that. Now, part of the decision was I was 4'4". If there was a 5 in there, I almost certainly would have done it. But I figured the 4 is sort of in between the 3 and the 5, and it was a tough decision, I have to say. A lot of people pressuring me that I should do it, but I had other friends saying, the radiation can go, the radiation control is not all that good. Now, in the last 5 years, as Rick has said, there's been probably some significant advances that maybe make it less dangerous, or maybe not even dangerous at all. I don't know. So that's something to consider. I think Rick sort of alluded to that just a second ago. So anyway, that was my decision not to do it after my prostatectomy.
Len, do you have some comments?
Well, one thing I'm a little confused on right now is, Jack, did you say that you said your PSA is right where they would like it to be? Does that mean it's undetectable?
Undetectable.
Wow. Personally, I would not get the radiation if you're undetectable and you were originally contained. I mean, it's conceivable.
It was going. I'm not sure of the technical terms, but it was going through the wall of the prostate.
Okay.
Okay.
But they haven't found any outside of the wall, is my understanding.
Right.
That's negative margins. You have to check your your surgical pathology report and make sure you understand everything about that with your urologist or oncologist, because little details make a big difference. So you are at least partially extracapsular, and so that means it may got out. But if your lymph nodes are clear and they found and you had negative margins, then you're probably in very good shape, and it's even possible you got a cure.
That's true, but they were suggesting that it could also follow the nerve system outside of that area.
Okay.
But Jack, let me just comment. This is Mark Finn. I had surgery and I had a tumor that was outside the capsule as well. Now my doctor removed I think all my seminal vesicles, removed some lymph nodes, but we ended up with clean margins. The question I would have for you to talk to your oncologist is, if they're going to do radiation, what are they shooting at? I mean, radiation, you need to have a target. And if in this case, they're just going to kind of say, well, we'll just blast away at your prostate bed, I just think you got to think about that. But what's their target? And the other thing is once you do radiation to an area, it's very hard to come back and do it again. And you really have there are some things that are going on at Mayo, but in general, you eliminated all surgical options in the future for that particular area because it turns everything into scar tissue. So I think that would be the thing to think about is this really the time to do it? I may get radiation in the future, but as my doctor says, in some ways, if you have metastatic disease, it's like whack-a-mole. I mean, until you have a specific target, it's not really worth going after, and so on. So.
I'm not sure.
My understanding was the radiation was for that general area in the event that some cancer did get out.
Right. So let me clarify that, because I'm not sure I would agree with Mark. If they suspect that the cancer is outside the capsule, what they're really radiating is not so much the prostate bed as the pelvic girdle, which is what I suspect they're after. And when they radiate the prostate, when they radiate the pelvic girdle, they use a little less radiation, it's more dispersed. And the idea is to try and nail any cancer that might have gotten into the lymphatic system, along with doing ADT that might kill any micrometastasis. And I think what they're saying is this guy had 4+5. He's got perineural invasion. That's the technical term, Jack, for it going into the nerve system. And there's a lot, it's very controversial whether that correlates with this metastatic disease or not, but there are people that think it does. So let's just not blast, but let's cover the pelvic girdle and give you the best chance. Now, I mean, you were T3. If they staged you as T3, and that's why, to me, I wouldn't have a second thought. If they staged you as T3, that means they found disease outside the capsule. That's what T3 means.
Okay.
So I don't know what the T3 is exactly or where it is, but they felt that there's 4+5 disease outside the capsule. Otherwise, you'd be T2. So
right, I'm looking back some of the.
So on that, all I'm saying is that on that basis alone, T3, 4+5. If it were me personally, I'd be looking to do pelvic girdle radiation and hormone therapy. We can talk about how long the hormone therapy should be for, but certainly, and if nothing else, we know that one good reason to do hormone therapy is that it makes the radiation more effective. But we've just got to move on because we've got less than an hour and a lot of people to talk to. But Jack, what I'd like to do, it's really if you can get in right at the beginning, then we know how many new guys we got, and so we can sort of manage better. But these calls are every week. It'll be Monday, and so if you can come back on Monday, we'll take a little bit more time, and hopefully Peter will be on, and I will also be sure to connect you to Peter.
Okay, so the next meeting's at Monday at the same time?
Monday at 8 o'clock.
Okay.
Because many years ago, when we only had 8 o'clock meetings, we had a lot of guys who complained that we were starting to. So we then started some meetings, the Tuesday meetings at 6 and the Monday meetings at 8.
Okay, enough said.
Okay, thank you, Jack, and thanks for bearing with us.
Rick,
Okay.
I am on and I've been listening.
Oh, okay. Well,
the simple thing is I waited, I made it 11 months. I waited till 0.2 on my PSA, and then we zapped it. Then we hit it.
Right. What was your? How are you staged, Peter? And what was your? Gleason?
I was Gleason 9, T3, seminal vesicle invasion. Yeah, but we waited until it climbed to 0.2 on the PSA, and then I went in for radiation. I made it 11 months.
Peter, can I? I'm going to
sure.
give.
Yes.
I'm
do it.
I'm going to give Jack your email right now, and
okay.
Jack, drop Peter a line.
Okay.
And he'll send you his telephone number. He's in Maui. It's a tough life. He's in Maui, in Hawaii. Okay.
Yeah, so I recognize that.
Right. You have a bit of a time difference, but Peter, go ahead and give and give Jack your uncanny.
It's Peter K at ancan.org.
Peter K at what?
K at ancan.org. ANCAN.org.
.org.
ANCAN.
NCAN, got it.
Yeah, AN Alpha Nancy Charlie Alpha Nancy.
Alpha Nancy Charlie Alpha Nancy.
Yeah, .org.
.org.
Perfect. Send him.
Great.
Send
Thank
him
you.
because what he tells you is a lot better than what I tell you because he's been through it. So that's what I might do, but that's what Peter did do, and you'll find out where Peter is now. We just don't have the time to go through it. But come back on Monday.
Okay, we'll do.
And you, Mr. Finn, you come back on Monday too. We haven't. All right. Okay. Next, let's go to Len. Len, you're up.
Oh, maybe we should go to Thibaut if we can hear him. Thibaut, you want to speak up, see if we can hear you? No, we can't. Sorry.
Call in. Call in. Call in on the telephone.
Yes. Telephone.
Yeah, call in on the telephone and leave. Yeah, yes, and leave your and leave the picture on, and then we'll hear you. But you'll just have to mute. You'll just have to mute the go-to meeting. Len, why don't you start whilst we're waiting for Thibaut to call in?
Yeah. All right. So, quick recap. Diagnosed in 2014 with Gleason 9. I've had ADT and radiation, and I have been on drug holiday for 21 months with I had been a stable PSA at 0.5 all that time until 2 months ago it started rising. So we did an Axumin scan and the results were inconclusive. at Mount Sinai, they recommended a follow-up MRI, but between myself and my oncologist, Dr. O, at Mount Sinai, we decided, or I proposed to him that instead of the MRI, that I get a more sensitive scan, either the gallium-68 PSMA scan at UCSF, or there's also a clinical trial at the NIH for F18 DCF PYL, otherwise known as F18 pill. And this is supposed to be the most sensitive of all thus far. So I've actually got applications going for both of these trials. I suspect I'm going to wind up going to Bethesda for the NIH trial, for the PYL. And they won't even put me on the waiting list, unfortunately, until I have met their prerequisites, which is to have a full body bone scan, technetium 99M, plus a CT of the chest, abdomen, and pelvis. It's unfortunate, in my opinion, because the technetium bone scan is primitive, in my opinion anyway, far less sensitive than the Axumin scan, which I already had. But this is part of their protocol. They said they can't violate their protocol. So those, the bone scan and the CAT scan, I've got scheduled here in Sarasota for next week. And then finally, I can get put on the waiting list for the NIH trial for the F18 PYL. That's about it.
Okay.
So it would be an interesting head-to-head comparison there of the Axumin scan versus this supposedly most advanced scan, the PYL.
Yep. Okay. Anybody want to talk to Len about how he's proceeding, about the trials or the comparison?
Actually, I have a quick question.
Go ahead, Marguerite.
Yeah, then what PSA do they want? Do they require before they do the gallium scan?
Oh boy, is Peter on the call? I'm not sure about the gallium. I can tell you for the PYL, they only.
Oh, no, you're doing the F18, right? Sorry. Do they require a certain PSA number?
Yeah. Peter, you got to mute yourself for a moment. I can't hear.
Peter will definitely come back to you, so you can respond. But we're just getting feedback from you. So to answer your question, Marguerite, and then we'll go to Peter. The sweet spot for the gallium scan is probably somewhere north of 0.6. Optimally, Peter was sort of at the bottom edge, 0.82 or 0.83, and anywhere north around 1 to 2, that's where they feel that it shows the most. Now, can you see anything at 0.2? You can. But do you see as much as if you waited? No. So that's the trade-off. I think that the 18F PYL scan might be a little bit lower, but I'm not sure. Do you know, Len, if the
yeah, I can tell you that the NIH says your PSA must be at least 0.2. So that's their floor.
Mm-hmm. Yeah, but the thing is that I don't think the people that we've known and seen, they don't get as good a result. Does that answer your question, Marguerite?
Yes, thank you. And then how long do you have to wait to get this F18 scan? Is it, do they sign you up as soon as you send in the required reports?
Yes, that's my understanding from what they told me. And I believe that originally they had a little difficulty getting the radio tracer, but they've lately been getting more of it, and they're able to treat more patients each week. So I think that once I'm on the list, it'll be about 3 weeks.
That's pretty good.
Yeah.
Okay, that's great. Thank you.
It's the 18. Don't ask me why, but it's 18FPYL as opposed to the F18 fluorochloride or whatever it was. Peter, tell us what your input is on this.
Yeah, well, Len sent out some statistics the other day. The closer you get to 1 to 2 PSA, the better your results. It's not that it's not going to find anything, but your chances of finding something and getting a good result are much improved if you can get your PSA up around 1 or 2.
Thanks, Peter.
Very good. Thank you.
Okay, so we're gonna move along. And Thibaut, can we hear you? Are you on the phone now?
Yes, number 3. Can you hear me?
We can hear you. Yes, we can hear you. And for those of you who don't know Thibaut, who's one of our longtime favorites, Thibaut has done some pretty amazing trials. The most recent of which was to have all of his bone marrow replaced in conjunction with bipolar androgen therapy by Sam Denmead at Johns Hopkins, and from which Thibaut got some benefit, but nowhere near the benefit that he had hoped to get. Thibaut, with that introduction, it's back over to you. You look good. I'm delighted to say you look good. That's the first thing. How you feeling?
Well, the only good thing I got from the bone marrow transplant is the process made me so sick that I lost 40 pounds, and I've kept it off ever since, with the exception of about 10 pounds that I have regained in the form of lymphedema, mostly on my left leg. So that doesn't show up in my face, so I still look like I'm 40 pounds lighter. Oh, my kid just walked in. Boys, I am talking on the phone, so I need to be quiet, okay? So the bipolar androgen therapy had a temporary effect, as it often does. The bone marrow transplant didn't have any benefit. My PSA doubling time returned to its usual 2 months, and so I had to start chemo. And the last 3 months, my PSA has been bouncing between 1,500 and 1,600. So I'm stopping chemo, and I enrolled in a trial led by Enzalutamide with lutetium-617, and I've done the screening CT and bone scan, and the remaining scan for my screening is the PSMA scan. I have to be determined to be PSMA positive, or I can't be in the trial at all. Now, they say I've got an 80% chance of being PSMA positive, but I think the chance is even better than that, because I have lots of PSA and lots of cancer, and prostate cancer tends to be heterogeneous. So if none of that is emitting PSMA, I would be shocked. So the real danger is that once I get into the trial, there's a 1 in 3 chance I'll be sent to the control group and not get the experimental drug.
Where are you doing the where did you say you're going to do the trial?
It came to Maryland. I didn't have to travel for it. It's in Towson at Chesapeake Urology.
Okay. Well, let's hope to goodness that you get into the right group. Are you paying? Are they charging you, or is this a freebie? Is it so much a
No,
session?
and in addition to not charging me anything beyond, I mean, when we do CT scans and bone scans that I'd be doing anyway, then my insurance gets charged for that. But the experimental drug is paid for, the PSMA scan is paid for, and they're paying for the travel. They're paying for the trip to Houston for me and a companion.
Oh, so you're doing it at Chesapeake, but you're getting treated in Houston?
No, everything is here except the PSMA scan. They can't do that here.
Oh, okay. Because I suspect that Houston lab is the one that Rob Garesisol used. That's where he got his treatment, but he paid. And someone else we know paid in Los Angeles. So I'm delighted to hear that you're not having to pay. That's great news. And you know what?
Yeah,
if, God forbid, it happens that you don't, we'll work with you, because we keep hearing about different places where it's available. I just heard this week of a freebie. Mike Scott put something on. I forget where it was, but he mentioned that he just heard of a lutetium-177 that isn't costing. So let me quickly go out to everybody who's on the call to talk to you. Who'd like to say something? Who'd like to say hello to Thibaut?
I want to know why you're draining a pool in the middle of January. I saw dirty water draining a pool into the yard.
It's a hot tub.
Hot tub.
It's a hot tub. My wife gets in it pretty often with her friends and doesn't remember to put some chlorine in when she's done. So the water was pretty awful. They were starting to get out, start scratching and itching, and that's a bad sign.
I'm not sure what kind of economic class I'm in. I didn't even recognize the hot tub. I thought it was a swimming pool.
It's a 6-person tub.
Well,
so
good luck.
anyone else? Anyone else want to talk to Thibaut about either what he's done or what he's going to be doing? Any questions? Thibaut, one thing you did miss earlier on is Mark Finn, who you can see talking about a possible trial that he might be doing that would combine enzalutamide with, say it for me, please, Mark, because I don't have it in front of me. You're muted. You're muted.
Mifepristone.
Mifepristone.
Actually, if you look at the, Len was very kind to point up a NIH
Yeah, I
study.
followed that link. And I don't think, I wouldn't be worried about the increase in testosterone and DHT because you're castrate resistant, so that shouldn't matter.
Well,
So,
the theory that was put out was that maybe this is, the combination is working something like along the lines of the BAT. But, as you say, with the BAT, it only seems to have a temporary effect and then it returns. Have you? Yeah.
There have been a few people that have done well with it for a couple of years, but it was just a few months.
All right. Well, look, we'll keep moving along. And Len, did you want to say anything to Thibaut? Did you have anything for Thibaut before we move on?
I was just wondering, Thibaut, if they explained any of the potential side effects to you, what to expect?
Yeah, the one part of the body that it goes to more than the rest is the salivary glands. So, but I hear it's not that bad. There is a chance of having dry mouth for the rest of your life. They give you some special mouthwash to use during treatment that's supposed to reduce the risk of that.
Okay.
Okay.
And I guess there's a little bit of, any radiation treatment can cause fatigue and whatever.
Some people say that the salivary issue is temporary, but everything I've seen is that it's pretty much permanent, as you said, Thibault. I don't know if it kills something in the gland or I don't know what it does, but apparently it is permanent.
Well, as my
Rick and I, go ahead.
Go ahead,
As
Thibault.
my
and then
PSA
Len.
goes up, it's more than just the number these days. I have more pain, and the last week I've started seeing blood, so a little side effects from the treatment are not a big deal compared to what's going to happen without an effective treatment.
Do you have a palliative care guy on board, Thibault?
So far, I'm getting my opioids from my primary care doc. I like him. I don't have anybody that specializes in it. I asked about that at Johns Hopkins. They don't really have that for outpatients.
I'm surprised that they don't have a palliative care group. I push them a little bit at Hopkins. There's got to be some palliative care for outpatients. I mean, it's a NCCN hospital. But
I know they do for
yeah, well, I'm pretty sure they should for outpatients. I mean, I'm making a note for me to look, but take a look.
Do the opioids keep it under control, Thibault?
Yeah, I just take an OxyContin every 12 hours and a little bit of oxycodone as needed, and it works. It keeps it under control.
As long as you stay on top of it. Don't get behind it. Stay on top and in front of it.
Every time I start to feel little pain, I take an extra pill, another 5 milligrams of oxycodone.
Okay. Len, you just want to address, I know, you want to make the point you were going to make for Jay?
Yeah. Rick and I just shared an article recently about the side effect of salivary glands from the lutetium treatment. From the article that we read, they were saying that there was severe salivary gland damage and permanent with actinium-227, not so much with the lutetium. The lutetium-177, this article claimed was temporary, and that so there was recovery.
Yeah, it's worse with actinium. The lutetium, not that bad, I hear.
Right.
Yeah. And also I think they adjusted the dose. I think it was dose dependent, so they gave a reduced dose of the lutetium and of the actinium. Of course, the downside was that the therapeutic effect was less when they de-escalated the dose. But so it's a trade-off.
We're going to move on because we still have a number of people to try and get to. Alfat, do you want to give us a quick update on where you are, how you're managing on that monotherapy?
Yeah, I'm glad to. Hi, this is Al. So I had started monotherapy with Erleada after my treatment with Firmagon has sort of petered out. My PSA was hovering around 5, and my T levels were down well below 15, usually below 10, even in single digits. So I felt that wasn't going anywhere, and I was able to work with my oncologist and my insurance company to get that covered. So it's been, about 5 or 6 months now that I've been on that, and my PSA went down to almost not detectable, went down to 0.05 from the last time we spoke. I was having, and I wasn't sure what the side effects were from, but I was, experiencing, some, what I self-diagnosed as motor neuropathy. I'm still waiting to have a neurologist. Just very heavy feet, really limping along like an old man, joint pain, no more lethargy than I was having from the Firmagon, but enough that I was going on vacation and I called up my oncologist and I said, I want to cut the dose in half while I'm away and see what happens. And he said, yeah, go ahead, So what happened was the last reading I had was still virtually the same at 0.06, but my T levels, which had gone up while I was taking the Erleada as a monotherapy, up to well above my typical values, up in the 400s, the middle 400s, dropped down to 315. So it seems pretty clear that the Erleada somehow was driving up the testosterone levels. At least it came down when the dose was cut in half. I'm going to have my next PSA test result in 2 weeks, and I'll have a follow-up appointment with the oncologist. And if my PSA stays, down low around that level, I'm just going to stay on half the dose, which is 120 instead of 240, until until the PSA starts to go back up. I've been reading a lot these days about circulating tumor cells as another index of metastatic activity, and I want to see if I can get a blood test. They call them like liquid biopsies. If anybody's been reading up on that,
Yeah,
and I want to see if I
very familiar.
I want to see if I can detect any what my level of circulating tumor cells is. And I want to use that as a backup measure to the PSA. And then I'm just going to keep doing this empirical trial and, keep trying different alternatives and see how long I can ride this out.
So let me address the CTC because we've actually just had a couple of sessions. Ken, are you with us?
Yep, yes. I'm here.
Ken, you want to talk to Alfad about CTCs and PSA levels?
Well, I'm not that well informed, I admit. I only know the little bit that I know. And all I know is that this liquid biopsy, at least at Foundation One, as far as microsatellite instability, they basically have, I don't think they have a very good mechanism to actually grade whether or not an individual has high microsatellite MSI or MMR. They do in fact state that they can grade it, but I mean the results that I had received was that it was undetermined or indeterminable. So
and what's your PSA level, Ken?
My PSA at the moment dropped down from 1 to 0.8.
0.8.
Do you have metastatic disease? Has that been identified through any imaging studies?
Yeah, I had a PET scan in Indiana 2 weeks ago, and I have 3 spots where it shows up within my skeletal structure. One on my, I do, yep.
Yeah. So that's similar to me. So I know I have metastatic, bone disease. So that obviously there's something that's migrated from the prostate to the bone. And the thought is that these circulating levels, like I said, I'm still educating myself about it, but they're sort of like an independent measure of tumor activity as the tumor is metastasizing and going into other regions. These tend to, be byproducts of that process,
Right.
at least as I understand it.
Right.
So, they're not good for diagnosing cancer. There's a lot of false negatives. But I'm not concerned with diagnosis. I'm just concerned with getting another biomarker or surrogate measure that I can back up the PSA levels with, because at very low levels, PSA becomes less and less a good indicator of tumor activity.
Right.
There's just not enough.
What I want to point out to you, Al, is that we've had a couple of guys that have tried to get CTCs analyzed at levels around 0.2, 0.3 and less, and they have not gotten a result, and they have been metastatic. So,
So I mean, the worst that'll happen is nothing will show up, and then it won't be possible.
Right.
But other, I won't know that until I get my initial level.
Right.
And if I get any trace level, then I can use that to back up the PSA. So I just want to have, I want to limit my exposure to the imaging studies that I've had. I've had so many radiation enhanced studies that really I don't want to bombard myself unnecessarily with that stuff.
I want to keep. Unfortunately, we've got to keep moving along here. But I would encourage you to call the customer service folks at Foundation Medicine. They're very, very good, and ask them as to what results you might get if you're metastatic and you have a very low PSA. Just bounce it off them and see if you don't get a good answer from them. Let me know, and I'll call David Marshak directly.
Thanks a lot. I appreciate that.
Okay.
Anybody else? Doing great.
Oh, good. Okay, you sound great.
Yeah, feel very good.
Okay. And so, anybody else have any questions for Al on his monotherapy? I did have one quick question. What's the theory that the apalutamide is stimulating testosterone? Do we have a theory on that? How it's happening?
Strangely enough, when I spoke to my primary care physician about it, he came up with an interpretation. I've spoken to the oncologist; they don't understand it themselves, and it's unanticipated because very few people are taking Erleada as a monotherapy. So you don't see it because the ADT medication would mask any effect like that you would have.
Mm-hmm.
I'm sort of like an N of 1 as far as this goes, as far as I can tell.
Yeah. All right, we must move on. Elaine, talk to us a little bit about where your husband's decision making is and the liver mets, et cetera, et cetera.
Yes, thanks, Rick. Well, when I chatted last time, I think 2 weeks ago on the call, we were hoping to get a biopsy done. We had an ultrasound done last week with the hope that we could do an ultrasound-guided biopsy. Unfortunately, the interventional radiology people said that the lesions were too small to biopsy. And these are 2 lesions on the liver that are less than an inch, I guess, in size. So in listening to what you were talking about tonight, and Rick, you had mentioned Foundation Medicine before, if they can't do the biopsy by going into the liver and taking out a sample, would the Foundation One liquid then be an option for us?
It would. The results are not always as reliable, but the PSA level, and also you've got to a particular situation in the type of disease that your husband has, and you don't make a lot of PSA. But yes, it definitely could be an option. Again, I'm not a doc, but I would think so, and it's something that's certainly worth discussing with the doctors.
His PSA is currently at 5.5. So he's been on Xtandi since March of 2018. Started off at 15.53 PSA, dropped down to 3.5 in July of last year, and then it's been slowly going back up to the 5.5. So, does this suggest that this Xtandi is no longer working then?
Well, you know, when your PSA starts to go up and you're on one of these drugs, they tend to think that it's not working that well anymore. But there are many situations and many docs that will leave you on them for a while whilst they're figuring out what the next step is. So it doesn't mean to come off of it. But let me throw that one out to the group. I mean, what's the group's opinion on a rising PSA whilst you're taking a second line anti-androgen?
Elaine, this is Jake. This is just a personal opinion, but if the Xtandi brought it down from 15.5 and you're down to 5.5, even though it's rising slowly, you're still getting some benefit from the Xtandi.
Yes.
It's not working totally, perhaps, as good as you'd like it to, but it is still working. Because if you stop taking it, most likely the PSA would skyrocket.
Okay.
So I'm kind of in the same situation. I'm on Xtandi, and my PSA has been going up, and but it is still working to a degree. And you run out of options after a point.
Well, because of these two lesions, and I mean, we were pushing for a biopsy because I don't know if they truly are. He doesn't have any mets anywhere else in the body. It's showing two lesions. They can't tell us for sure whether it's a metastasized prostate cancer or a benign situation. That's why we were pushing for the biopsy. The radiology seems to think they are a metastasized situation, so they're only offering the standard treatment, which is docetaxel, or a clinical trial. The clinical trial they're offering is Keynote 365, and the one group that he would be eligible for would be the Keytruda with combo of docetaxel. So there's that choice, or just going with straight docetaxel. But I mean, I'm concerned because what if it's not a MET situation, and we're and they put him on this on the strong drug.
Well, let me just clarify something. When was his PSA 15, and how long has he been taking the enzalutamide?
His PSA was 15.5 last March 2018. Brought it down to 3.5 as of July of last year, and then since July it's slowly going up to 5.5. So he's been on the Xtandi for not quite a year.
Len, do you have any thoughts?
Unfortunately, no. I don't have anything to add to what you've already said, Rick, about continuing the enzalutamide until another option is identified.
I don't know if we should be waiting to see if these lesions get larger and then get the biopsy, or if we should take that risk, or if we should start on chemo right away. I guess it's a further discussion with the doctor, but.
Well, I mean, I think that Here, I guess, if it were me, I probably would try and get the liquid biopsy run.
Okay.
Before you start the chemo, and I think if it were me, I would be diving into the chemo. The question is, what's the right chemo? Is it docetaxel, or is it docetaxel plus carboplatin, or is it carboplatin? Yes, we acknowledge we don't know what the liver lesions actually are. This is true, but at the same time, your husband definitely has had a fair amount of PSA. He's responded to the enzalutamide. Now it's going back up again. So there's something that is going on there. Have you gotten any second opinions on whether those lesions can be biopsied?
No, because I just found out today. Now, Bill Burhans has told us about an oncologist at Roswell. So we're looking into getting a consult down in Buffalo.
Right.
So I just started that process today. And the other question I had, though, other than chemo, I've been reading up on, with liver mets, other forms of treatment. One is called chemoembolization. Another one, there's ablation therapy. There's a bunch of others that apparently has been used with liver mets. They don't seem to offer that in Canada other than in a clinical trial.
Right.
It's what I'm told.
I think I sent you 2 links there. TheraSphere and Certex are the people that make these liver embolizing spheres that with yttrium. Yttrium-70 is the active agent. I happen to know a little bit more about it only because I was talking to a veterinarian who uses these treatments, believe it or not. She's a leading veterinarian, and I happened to see her over the weekend, and we were talking about this. I think that Dr. Chatter is very good. He's been Bill's doctor for a long time. Bill, needed to move further afield because he felt that there were other opportunities, but he's convenient to you in Toronto.
Yeah.
But I do think that an interventional radiologist should take a look at the MRIs or the CT scans and give you a second opinion about whether they can biopsy those 2 1-inch lesions. I wouldn't. Well,
it was interventional radiology that said they could not. That it was not. They were not able to do it at this time.
I can get a second opinion.
That's what I'm saying. Oh, I see what you're saying. Okay.
Yeah, I mean, I go to another interventional radiologist to confirm that those 2 1-inch lesions are not biopsiable. I don't know enough. I really don't.
Okay.
The fact is that if they were biopsiable, it would solve a whole heck of a lot of problems.
Yes, it would. As a Canadian, do you have any? What is the cost of using Foundation One or Foundation Medicine? I mean, approximately, what would the cost be?
I don't know, but I will connect you to David Marshak, and then he'll respond to you.
Okay, thank you so much.
I did have a recent discussion with Foundation Medicine about the cost of their testing, and the way they explained it to me is that, and again, it's U.S. related, but that they will initially bill the insurance company, and they bill them approximately $10,000.
Whoa.
And however, quite interesting is that for the patient, if it gets denied by the insurance company, then the cost is $3,500. However, you can be eligible for financial assistance, which I did receive based upon a certain amount of income, and I got a 90% discount, so the cost goes down to $350.
Oh, wow.
So let me address that quickly. I'm aware of what's going on in the States, and most people don't pay more than $500. Their financial assistance is coming from the drug companies, because obviously if you get diagnosed with a mutation, then it's very profitable for the drug companies. So they are providing Foundation Medicine, and Foundation Medicine is shepherding those funds. Now, I just don't know what the situation is for Canada.
Okay.
But that's why I want to send you to David and see what could be arranged, or if there's any possibility, or if not, he may know for Canada. But what I really would rather see, and what Carl was talking about, I think, is for a tissue. I don't know if the costs are the same for the liquid biopsy. I think they may be a little less, but I'm not certain.
Yes, definitely for tissue.
Yeah, but I've got it on here to follow up, and I'll connect you.
Oh, thank you so much, Rick. Thank you.
As a pleasure. Oh, and by the way, Len, did you give Mark Finn Alfat's email? Thank you.
Yep.
Thanks a million.
I did.
Thank you. Okay. Well, we're almost at time, and I still want to talk to Carl and to Paul and to Jay Mills. Marguerite, can you hold your question?
Not a problem.
Okay. Jay, how are you doing? Jay, I see your phone's on. Are you with us? Mr. Mills? Well, we'll come back to we'll come back to him. Paul, one of your two questions, which one do you want to go for?
I just want to know what I should be expecting to pay for the 3 secondary drugs. I know one of them's generic, so it should be pretty cheap. But when I go on the internet, it looks like $3,000 a month. So I'm sure there are some things I don't know about how to get it less expensively.
Okay, so I'm just going to say a couple of things, and then there are a bunch of guys that are taking these drugs who can probably give you better information. But there is a donut hole. Are you familiar with the donut hole concept?
I've heard about it. I'm not up on it, but the donut hole exists with all insurance companies, or all the drug plan?
It's a Medicare concept, so it exists. It exists with all the drug plans, and some of the drug plans, I think, you pay a lot more for, and you can lose the donut hole, but I'm not certain about that. I think I would have to check that out. But by and large, what it means is that you're covered up to a certain level. And I don't know what these levels are for the coming year, but they're usually around $3,000 or $4,000 worth of coverage. You then have to pay out of pocket about $2,800, and then after that, your cost is very, very low. And I'm going to throw it out to some people that, I mean, there are people. Dennis, I think you know about this, and who else is on Medicare that has experience on how to handle the cost? And by the way, there are also assistance programs with Johnson & Johnson, with Pfizer. The assistance program, Johnson & Johnson's assistance program for Erleada is very, very good from what I know. We also have good connections there, but somebody want to, Dennis, I see your microphone's on. Talk to us.
Yeah, excuse me. I'm just looking at my Humana is where I have my Part D supplement. And stage 2 with the call, and I think this is the initial coverage period ends when the maximum prescription cost paid by you reached $3,750. And then they go into what you pay, how much you pay. But the big one is, I believe, the coverage gap. That's I think the same as what they call a catastrophic thing, and that's $5,000 a year. Now, for me with the Zytiga, I have a little bit different deal than probably most anybody here. My ex-employer was GE, and they have a little-known program for retired executives where you can get reimbursed for any out-of-pocket cost over this maximum, this coverage gap. For this past year, 2018, it was $5,000, whereby my out-of-pocket cost was $11,444. So I'm going to get a substantial refund this year from my ex employer. But it's just something you know, whether you're still working or retired, whether your previous employer has any such programs. This is a little known one. It's hardly advertised at all. And I applied for 2017 what I spent and got refunded promptly for anything over the max. And I just got this out in front of me now because I'm just requested the forms for filing this for the 2018 year, which will help out here tremendously.
Len, what was your experience with the Zytiga?
I was only on it for 3 months, so I never hit the donut hole. But I can't remember exactly, Rick, but I know I was paying less, definitely less than $100 a month out of pocket.
Mm-hmm.
Now that's I had Medicare with Aetna as secondary. I think it all depends on what kind of insurance you have.
Peter?
Definitely.
Peter, what's your experience been? You were on Zytiga for quite some time.
I think he left.
Oh, okay.
I'll tell you one thing. I just posted this on Facebook, but Johnson & Johnson is raising the price of about 15 of their drugs, including Zytiga, and they're raising them anywhere from 6 to 15%. So probably Astellas and the other ones will follow suit. Just, you know, again, like Len says, it depends on the insurance that you have. I have Medicare A and B, and then I have a secondary insurance through my old employer, and they pay my secondary insurance, which is Blue Cross. I normally have an 80% copay, but for my Xtandi, my copay would have been only $35, and Astellas pays that $35. So I have 0 cost per month. It varies from company to company. You need to check. There's no one answer.
But you have the Medicare D?
No. What I have is, you know, kind of like the equivalent of it, but it's not exactly Medicare D.
Well, A and B is not drugs. So what is it that you have that covers drugs?
I have a secondary insurance through my ex-employer. Cost me $300 or $400 a month to keep it, but They tell you if you have that, you don't need Medicare D. Basically,
Oh, is that right? If you have a good secondary, you don't need Medicare D?
well, that's what my insurance company told me. And that way I don't have a donut hole or anything. Generally my copay is 80% of the drug cost. But for some reason, and I'm not complaining or questioning it, but Blue Cross covers all of the expense of the Xtandi, which is $10,000 to $12,000, depending on who you talk to. They cover all but $35. And then I applied with Astellas, who sells, I think it's Astellas, right, Rick?
Yeah, Pfizer. Yeah.
Yeah. I applied to them for help with the copay, and they pay the $35, and yet they have to renew it every year, once a year. But my net copay is $0.
Wow.
Yeah.
Carl, can you explain for better than I can for Paul the donut hole?
It's been a little while since I was dealing in the Medicare arena, and I'm very rusty right now on that. But basically, as you have mentioned, there is catastrophic coverage, and your copay goes down dramatically to only several dollars per prescription. But you have to hit that. You have to go over that $5,000 number out of pocket before you become eligible. And for most of us, unfortunately, especially on Zytiga, which I'm on, I'm fortunate to not to have out of pocket, but that comes up very quickly where you hit that mark, and after that, that catastrophic coverage is a pretty low number per prescription.
Catastrophic from who? From Medicare?
Yes, that's the Part D Medicare prescription plan.
I don't have that. Okay.
You don't have Part D?
No, I don't have Part D. I've got Humana.
Oh yeah, but Humana is the insurer. The Humana offers Part A, Part B, Part D, Part G. I forget what else. Part F, Part G.
Well,
Part
I have a drug plan with them. I pay about $30 a month.
I'm sorry, did you say you do have a drug plan or you do not?
Drug plan with Humana, that's right.
Okay,
that
so
sounds like, and if you're on Medicare and that is Part D, and Humana is one of many companies that offer a Part D prescription drug plan.
Right.
All right. So maybe I'm on Part D through Humana.
Right.
You are.
What?
Yeah.
Is that right?
Yes.
Okay.
So what you have to do is you've got to look at there, and you've got to see when they'll cover you up to a certain amount, and then it's on your dime, and then after that, it'll be negligible cost. And that's basically what your annual exposure is. Somebody mentioned before it was around $3,750. It's usually somewhere in the region of $2,800 to $5,000. It sort of differs. It depends how much you're paying in the early part. And the donut hole is going down every year. It's through now to 2020. So I just don't know where it is, but Humana will explain to you. That is the most you can pay. And then beyond that, so whatever that is, that's the worst. And then what you do is you apply for financial assistance to whoever makes the drug.
Okay.
And like I say, I know with apalutamide, what's his name? He's in Tennessee, I think. We haven't heard from him for a while, but he got a very quick turnaround from them, and it's costing him about $10 a month.
Okay, which is the one that's generic? Isn't one of the
Zytiga is available in a generic prescription, but from what I understand, it's just as expensive.
Okay.
In other words, generic.
I have
a little bit
the
less.
generic. I'm using the generic of Zytiga, abiraterone. It's instead of Janssen Pharmaceuticals, there's Apotek. And again, for me, out of pocket is $0. But when I went online to look at the retail cost that my Briova, my specialty pharmacy, was charging, it was $10,200 for the retail price for Zytiga. For the generic, it was $8,300. So not a big decrease.
Wow.
And why are you paying $0? Because you've burnt through your exposure. Oh no, you're not on Medicare.
Correct. I have private coverage.
Oh yeah, private coverage. Okay. Okay.
Yep. Paul, I believe the typical situation is that the first generic company to get approval for their generic drug, they get what they call 6 months exclusivity. So no other generic company is allowed to compete with them. However, following that 6 months of exclusivity, so they can charge a lot. Following that 6 months of exclusivity, any other drug company can jump in the market with its own generic, and that's when the prices plummet.
I see. Okay. Okay.
Thanks, Len.
All right.
All right.
Anybody on apalutamide? There's a new one that came out this year. No one in our group is on apalutamide.
Yeah, Alpha is.
Yeah, I'm taking that. My insurance company covers everything, but I have Medicare as primary and Blue Cross. My New York State insurance plan is secondary, but Medicare covers the entire cost of that.
In a discussion with Dave Rubin, I announced that I would be closing my Patreon
Like
account.
$10,000 a month.
So I am doing so, as Dave.
Yeah. Okay. All right. Let's see. Well, I can't think of any more questions right now. I'm just wondering what everybody's paying. But so it looks like I should expect that unless I find some loophole somewhere, I'm going to be paying like between $3,000 and $5,000 for the year, and then after that, I get covered.
Well, you should count on that as worst case, but you may be able to get financial assistance.
Right. Before financial assistance, right? Yeah.
Before financial assistance, yes, that's the case. Yeah.
What do you need to qualify for financial assistance? Otherwise,
we've got to move on. We've just got to move on because I got to touch base with Carl. Is Jay Mills back with us? No. Okay. Carl, why don't you had a couple of questions. Why don't you tell us what's on your mind?
I know we're into overtime here. To keep it short, I did have my updated meeting this afternoon with my oncologist to discuss my results, that my PSA is starting to rise, and what the plan of action should be at this point. And where we are tweaking the medication. I'm staying on the Zytiga for now. We don't fully believe that it is failing yet. So the oncologist has taken me off of prednisone and put me on a medication called dexamethasone. And I was not familiar with that before, but looking that up, it kind of makes sense that there's been favorable trials about that it can help bring the PSA lower. And we're going to be on that for a couple of weeks. I have a follow-up meeting in a month, and we'll see where the PSA is at that time. And it looks like we are talking about going on to olaparib since I am BRCA2 positive.
Okay, so first of all, Len, you want to comment on going from prednisone to dexamethasone? That's your that's one of the things that you once pointed out to us, right?
Rick, could you give me that again? I'm sorry, I had an issue here. I was choking on some water.
Oh, okay. Have you surfaced?
Yes.
Have you surfaced?
I can breathe.
Okay. Carl was just switched from prednisone to dexamethasone. As I recall, that was something that you had researched at one point in time. His Medonc feels that may help the effectiveness of the
Zytiga.
Zytiga. Yeah, you want to comment on that?
Yeah, my recollection is that there were some relatively small trials, phase 2 trials, maybe 20 to 30 people involved, where they had actually had people on Zytiga and prednisone. They stopped responding, and then they switched to Zytiga and dexamethasone, and they started responding again. And it's possible that there were also trials where right away their patients were put on Zytiga and dexamethasone, and they appeared to do better than those taking prednisone. But I'm not sure about that last part. For sure, the first trial that I mentioned, that I do recall. So responses improved when switched from prednisone to dexamethasone.
The only thing I want to say is that from what we know, the dexamethasone is a little stronger. There are guys on several guys on this call who have taken it. That's usually given right around the time you get your chemo. And then if you stay on a steroid, you stay on the prednisone. So it is slightly stronger. You may have different side effects. You may get a little more puffy from it. Water retention issues. What I don't know is how you mitigate that. Anybody have any thoughts on how best to what best to do with dexamethasone? Okay.
Yeah, my oncologist simply said it's very similar to prednisone, similar side effects. It's a very low dose, and I shouldn't have any significant side effects other than what I've experienced with the prednisone, which hasn't been much.
Okay, well, all of that is true, and the guys who take the dexamethasone with chemo get a large dose. So that's a big difference. So when I'm saying I know it has some other side effects. It may be that the dose is much stronger when you're getting it with chemo. But
yes, mine is at 0.5 milligrams. So.
Okay. So I'm getting out of my knowledge depth here. So did you have any discussion about being ARV7 positive?
Yes, and I was anxious to have the blood test, and the oncologist said, well, when we're ready to make a change in the treatment, that's when we do the test. He said if we do it now and if we do it a month from now, it could provide different results. So it doesn't necessarily make sense to do it now.
Yeah, it does, because what happens is that the people that fail the abiraterone can develop this ARV7 mutation over the period of time that they're taking it. Some people develop it very quickly, other people take a little longer, and some people are ARV7 positive from the outset. So, I've never heard anybody say that, but I understand what he's saying. Len or Peter? Len, any thoughts?
Okay, sorry, I was busy getting that article that I referenced before. I just put it in the chat box where 30 patients were progressing on Zytiga plus prednisone. They were switched to dexamethasone, and 40% went on to improve after the switch. What's this other question?
Let me just make sure, Carl, do you see the article? It's in the chat box?
Yes.
Good. Okay. The question was ARV7. And ARV7, when you developing ARV7 mutations, because Carl's doctor said we don't want to test you right now because you might not be positive right now, but you may be positive when we're ready to switch you. So we'll wait until we switch you.
Yeah, I had also just recently read about a study where I think it was 6 of 20-something patients who were ARV7 positive were still responsive to either abiraterone or enzalutamide. So it's not a if you're ARV7 positive, I would still go ahead with one of these second-line anti-androgens because there's still a possibility you could respond.
Right. Well, we don't know, but I think the bottom line, Carl, is the guy's right on top of it by giving you the dexamethasone.
Yeah. And also, just as an aside too, quickly here, the genetic mapping, which I had anticipated and was told that I would be receiving as a result of the clinical trial I'm participating in, I was just told today that they said, well, we don't have the full accreditation to be able to issue a report. So in other words, the Foundation Medicine, which I had said, let's still proceed. He said, absolutely. We sent it on to them yesterday, and Foundation Medicine will do their testing.
Oh, great. Okay. And if you have any glitches with all right. Well, and as far as the olaparib, I think that if you're thinking of taking the olaparib, you might want to talk to your doctor even early about getting it approved, well, the first, I think, bigger question, which is the right PARP inhibitor for you to take?
Yes, we definitely talked about that, and I mentioned rucaparib, which is the more recent PARP inhibitor, and he said that it would be a lot easier for me to obtain permission for olaparib because we know neither one of them or none of them are FDA approved yet. They're still in clinical trials. He said olaparib should be pretty easy for me to get approved for, but rucaparib, absolutely not, because I haven't been on chemotherapy, and that's a requirement.
Okay. I wasn't aware of that. What I do know, what I can tell you is we have very good contacts with the people that make rucaparib, and I also have contacts to Pfizer for the I can't think what it's called, the very strong one, talazoparib, is it? I wrote it. I sent it to you. Okay. I sent you an email with that. But it's a Pfizer drug, and we filed for that drug last year. I was on a small panel that reviewed it. I just can't remember the name of it. Talazoparib, I think, is it?
Well, it might be Lynparza. Is that the?
No, Lynparza is olaparib.
Oh.
Talazoparib, which is called Talzenna, Talzenna, or talazoparib. Here's the comparison. Rucaparib, which is called Rubraca, is 7 times stronger than the olaparib and talazoparib, which is made by Pfizer, is 100 times stronger.
Wow.
And we really don't know. Frankly, there's probably few people that would have a better idea, and it's just an idea, than Professor Bill.
I hate to.
So,
What is
go ahead.
strong? What do you mean by stronger?
It's more potent. It's potency.
I mean, it's effectiveness or effectiveness?
The
But
power
Not necessarily.
Okay. Oh yeah.
But basically, what it means is, yeah, basically, when a drug is more potent than another, it simply means you don't have to give as much of it.
Oh.
But that doesn't necessarily mean that it's going to be 10 or 100 times more effective.
Sure, that's what I was thinking. Sorry to interrupt,
Yeah.
but I couldn't understand.
No, it's a good question. Thank you, Larry. It's a good question. I hope I said it right. I don't think I said it's 100 times more effective. I said it's 107 times more powerful, I think is what I said. I hope is what I said. Yeah, stronger, 7 times stronger. So,
so Alcott, I'm just going to throw something on the table here related to drug potency. There's been a fascinating report about, I think it's Zytiga, on an empty stomach versus with food. Has anybody,
Yeah,
it turns out that you can get by with half the dose and pretty much.
I'm gonna cut you off, Al, because it's something we're very familiar with, and we're so late. I'd love to discuss that with you maybe on Monday. But yes, we're well aware of, and that is a different reason. It has to do with the fact that the Zytiga is processed through the liver. So if you take food with the Zytiga versus not taking food, it affects the potency of the Zytiga. But we can come back to that next time you're on. I mean, please raise it. Len, you just put something in the chat window.
Yes, I was talking about the ARV7 positive patients who nevertheless do respond to abiraterone or Zytiga, or enzalutamide.
Okay.
Not all of them, of course, but I think it was 6 of 21 had some kind of response.
Okay, guys, we're a half hour over. Thank you. We've had the patience to stay with us. There's just been so much today, and I think we may have even skipped over a couple of people. If we did, I'm really sorry. Jay Mills, we tried you a couple of times, but we couldn't get you. Are you with us now? No.
Yes, I am. Sorry. I had stepped away. Yes.
Sorry? Yeah, Jay, well, I will call you after the call because I want to find out, but we're a half hour over, so we've just got to, I just want to close out the call, but I'll give you a buzz in a minute.
That's fine. I'm fine with that. Thank you.
Thank you. Okay, bye. All right, everybody. The next call is next Monday, the 21st. And we'll talk to you all then. And anybody who I missed, please come on and we'll take your questions. Good night.
Good night, everyone.
Good night.
Good night.